For those of you that don't know me, I am a complete and utter fool. Why do I say that? It's because I chose to ignore my symptoms of significant prostate health problems for nearly 2 years before I did anything about it. I was getting up 4 times a night. I had terrible urgency. I knew I had a big prostate. That's bad enough if you're a member of the general public, if you like. It's even worse if you're a doctor. I should have known better. It's even worse again if you're a consultant anaesthetist that for 25 years had been one of the major anaesthetists in the urology department in Reading where I was working. I should have known a lot better. And this is why groups like these are so important at raising awareness, at getting to the general public. Where's the chap that was just speaking? Where is he? I just was interested to ask him a question about, I'll ask him afterwards, about anaphylaxis during anaesthesia is about as rare as hen's teeth. So anybody that's going to have an anaesthetic, it is incredibly safe. You're more likely to be mown over by a bus crossing the road than you are to have a death from anaesthesia. But who knows what it was. Okay, so I've been asked tonight to talk about a couple of things. What I'm going to do is I'm going to talk about one of them. Only because I know I have a reputation for going hopelessly over time. And I don't want to do that tonight. So, we were going to talk a little about NICE. I sit on the NICE committee as a patient representative for Tackle Prostate Cancer. So I know a little bit about what happens in getting new drugs to market. But what I really want to talk about is this elephant. The elephant that's in the room very often. And what is that elephant? Is it an elephant? Is it a storm in a teacup? Is it just pie in the sky thinking? We're going to talk about PSA testing. Now, a lot of you know a huge amount already, and I'm not trying to teach you, but it's very good sometimes to review our thoughts and to have some, know what's going on in the world. So what I'm going to talk about is a very personal opinion. Yes, I've been working at times with Tackle, with PSA UK, a bit with prostate cancer, a bit with all sorts of them. These are my personal thoughts about it. And there's a lot of misconception. There's a lot of misunderstanding in the press. There's a lot of rubbish talked, as many of you already know. So, what is it? Well, as you know, it measures this stuff called prostate-specific antigen. It's found actually mainly in semen, and its function is to liquefy semen. Semen goes very solid, very quickly, very jelly-like, as you all know, and then it becomes more fluid, so that the lovely little sperm can swim all the long way up and go and find that one little egg. So it's absolutely essential, prostate-specific antigen. But yes, it is found in the blood as well, much lower levels. Why do we use a blood test? Because it's a darn sight easier to get a sample of blood from people than a semen sample. Is it reliable and accurate? Because you hear all sorts of things in the press, don't you? So it's a blood test that measures that total amount of PSA in your blood. It is incredibly sensitive. The same test can measure anything from 0.00, almost nothing, up to 10, 20, 30,000 units. Same test done appropriately. It's a really accurate, sensitive test. And we know that PSA is only made by prostate cells. Nothing else in your body, give or take, can make PSA. So it's selective for prostate problems. And that's all. The trouble is, as you know, PSA is made both by normal cells and by prostate cancer cells. So both of those will give a raised PSA. And sometimes it's very difficult then to decide what is abnormal, what's going to be a test that's going to indicate the possibility of a cancer. But it is not a test for prostate cancer. It is a test of your prostate health. And we have to get that over to all sorts of people that should actually know better. 65-70% of men with a raised PSA won't have a cancer. It'll be due to something else. Then you know if you've got a large prostate, that puts your PSA level up. If you do rigorous exercise, it puts your PSA up. It may, after exercises, tip you into an abnormal zone. So it's important that you don't do things artificially to raise your PSA, as you know, before you have a test done. Trouble is, some men with a normal PSA will actually have a prostate cancer. I was one of those. My PSA was at the upper limit of normal for my age for 7 consecutive years. I was convinced it was benign. Now we're talking way back in 2008. We had no idea that prostate cancer was a whole spectrum of disease. It was either cancer or it wasn't. And we now know that there are some cancers that are so, yes, they're a cancer, but they're so slow growing, you may never ever need treatment. 1 in 3 men over the age of about 80 have a small, slow-growing prostate cancer, which is never going to kill them. They don't need to know about it. Why worry them? As we get older, and I found this really difficult to get my head around when I first started being involved with prostate cancer support, you need to look at what's going to kill you in the next 10 years. If you're already 85 and you've got severe heart disease, diabetes, and God knows what else, that's much more likely to kill you than a very small, relatively slow-growing prostate cancer. You don't need to treat that. And that's where we get into the realms of what's called active surveillance. And I've got to take into task, you didn't have watch and wait. You had active surveillance. And again, we get so many terms that people misunderstand. Active surveillance is, let's keep testing you. Let's keep a very close eye on you. And when things start going abnormal, we get in there and we treat it quickly. Watch and wait is for people with much more advanced disease who have taken the viewpoint, I don't want horrible treatment, but I do want symptoms controlled if I need to later on. So no radical surgery, but if you should get, let's say, bone secondaries, which can be incredibly painful, we're not saying you're not going to get treatment for that, symptomatic treatment. So again, it's important that we understand the things that we do. So I like explaining the PSA a bit like taking somebody's temperature. If you're feeling unwell and you take your temperature and it's raised, it tells you there's something going on in your body. You've got a fever, you've probably got an infection. It doesn't tell you where, it doesn't tell you what. It just tells you as a warning sign there's something that needs further investigation. And the more we actually look at a PSA test in that light, the more we will be able to educate the public. It is reliable and very accurate, but it isn't specific or selective rather for prostate cancer. And that's where everybody feels we should be doing something different. And there are other tests, but they're a confusion. I know that now many hospitals have changed the machinery, the analyzers that they're using for PSA, and the latest one is made by a firm called Abbott, and they will only report a different lower level of figure. It doesn't go into 3 figures like many of you would have had. And that for some people has been quite a shock. Nobody really told you. You suddenly were going along at, I don't know, 0.004 or something, and now you've got something which says it's less than 0.2 or 0.02. That's quite frightening for some people. And I think what we have to understand is we're setting a new baseline with that. Work from that baseline and see what happens. It's as sensitive. If you get a rise in it, it will be shown if it comes to a level which is clinically significant. And that's the important thing, clinical significance. Yet every lab in this country has to go under quality control. They get samples sent to them, they analyse and send off, and other places, the powers that be, look at those and they compare results. And if a laboratory's results are not within certain ranges, they, by God, will be taken to task. And that goes across the board for most laboratory tests. The figures are important, but it's interpretation of those figures which is even more important. As you know, a PSA of 6 may be normal for somebody of a certain age. For another person, it's highly abnormal. Why are we using PSA? What's the history behind it? How did it get started? Well, PSA was never intended to be a screening tool for prostate problems. It started way back when researchers were asked to produce a test that could positively identify ladies that had been raped. On vaginal swabs, they needed a test to say, yes, sexual activity has taken place. And yes, you can look for sperm, but that might not always happen. But that's how the PSA started in life. It then became accurately measured in blood. The PSA originally was only measured in semen. So then the blood test came in, but it wasn't accurately measured until 1980. That's not very long ago. And even more, it wasn't actually used as a screening tool at all until 1994. So this is a fairly new use of an old test. And even in those days, it was intended to follow the progress of already established disease, not necessarily to act as, if you like, a screening tool. And this is where all the complications, all the misunderstandings come. What's the difference? If I ask you, what do you understand by PSA testing? What is it?
Prostate cancer.
It's not.
Prostate cancer as well.
PSA testing is the process of collecting a blood sample and measuring it for PSA. That is all. You end up with a figure, and from that you can work out other things. PSA screening is using that blood test specifically for the purpose of early identification of prostate disease and thereby prostate cancer. So when we're talking about we're going to have a PSA testing event, that's all we are doing. We are not doing a prostate cancer screening event as such, although one of the offshoots of that will be that many men will have an abnormal PSA, will need further referral, and then go on to be diagnosed with prostate cancer. So it's all going on, I know, about the same thing, but it is very important that we know in our brains what we are understanding when we talk to somebody else about it. Why should you screen? Well, those are very easy, isn't it? It's the most common cancer in men in the UK. It is the second most cause of cancer death in males in the UK. It is the only major cancer in the UK which doesn't have a screening programme. I find that shocking, horrific, and we are all of us in the room. Does anybody, no, I can't ask you to put your hands up if you don't feel we should be screening for PSA. Because I know if I ask you, should we, you're all going to put your hands up. There are arguments for and against it. Appropriate screening programs, appropriately doing these things, will halve the death rate. That's proven. So it's important that we do it, but it's important that we do it in the right way. How should you screen? Just doing it once is a waste of space. It might tell you that one person has got a very high PSA. If it's a very high PSA, it may well be a cancer. But it's the guys at the bottom end, as you know, which are equally important. It's following the rise in PSA. So you need risk-based testing, not on one occasion, but as a beginning of a journey of regular testing. What do we mean by risk-based testing? That's taking other factors. Your family history, your ethnic grouping, whether somebody in the family's got breast cancer or ovarian cancer or not. All of those things you know about. That's looking at risk. And there are now some guidelines, not yet accepted by the government, but by a charity called CHAPS, that are looking at, if it's a red result, it's clear. You've got to go off on your 2-week cancer programme and get it dealt with. If it's an amber result, a bit equivocal, then you're going to tell those people you need to go and get it done again. Because it goes up and down a little bit naturally in life with activity or whatever. Regular PSA testing at an appropriate interval. If you're high risk and you've got a green result, you should be tested every year for at least 5 years. If you've got a green result when you're 80, you probably never need to be tested again. If you've got 1 or 2 minor risk factors, then you need to be done every 2 years or possibly every 3 years for other people. So it's looking at everybody as an individual and tailoring it to their disease, to their results. It's not a one-size-fits-all. I think in the past, if I'm going to be honest, we have wasted a lot of money by inappropriately testing people every year when they didn't need it. Yes, it's quite reassuring to do that, but if we can prove that you don't need it, and we can prove it properly with decent research, then we can actually save money, and increasing the number of tests that we perform won't necessarily increase the total cost to the government. And it's all about doing things appropriately. You know those risk factors, I'm not going to go through them. The one thing that we didn't know, as I said, when I was diagnosed, if you're in the top 1/4 percentile, that puts you in a slightly higher risk category. We're now talking, or some people are now talking, about only screening men with the highest risk. And I honestly don't know what that means. There's a lot of argument at the moment. PSA screening, and I was at a meeting, I'm now managed to get myself as a public observer. There is something called the All-Party Parliamentary Group on Prostate Cancer, and they regularly meet every 3 months or so. And we've been talking about overtreatment, we were talking about PSA screening. Sadly, there were probably on each occasion 40 people in the room, 8 MPs, perhaps 2 Lords. The decision eventually is going to be made on 2 things. It's going to be made on evidence actually presented to this thing called the National Screening Committee. They have very strict attitudes. Some of them, well, I can't actually, no, speak closer into the hidden microphone. They have always been against PSA testing. The Royal College of GPs still instructs its members not to bring up the possibility of having a PSA test when you're over 50. Everybody is entitled to it, and if you go and ask for it, then that's fine. You can get it done, and you should be able to get it done. But he can't, off the back of the cuff, say, oh, yeah, we do your cholesterol, we're doing your diabetes, let's see your PSA. He's not allowed to do that. And we're seeing lots of people, I'm sure in this group, there are people who were found entirely by chance, that they had a PSA done for whatever reason. And sadly, one of those reasons very often is the fact that they are privileged to have a company that gives them private health insurance and a regular checkup every year. One of my best friends is only alive today because of me. That's a pretty over-the-top statement. But about, it's going to be about nearly 10 years ago, I think. He was only 53. He had a works medical, ticked the box, blood pressure, cholesterol, diabetes, all that. And there was a box at the bottom which said, do you want a test for your prostate? And he thought, I'm only 53. I haven't got any problems. I don't need that doing. And then he thought, if I don't tick that box, my friend Steve will kill me. And he would have done. He went on holiday, had his blood done. 4 days later, lying in the sun in Rhodes, he gets a text message from his GP, please come and see me very urgently. His PSA was, I can't remember exactly, but it was about 20. He had no symptoms. And this is the other thing we've got to get over to people when we're talking about PSA testing. It's, you don't need symptoms to have an early prostate cancer. You all know that. But do the general public? Do we say that enough in a way that doesn't scare the pants off them? And if you're giving an awareness, so you mustn't send people out absolutely scared that they've got a cancer inside them, although they haven't got symptoms. It's all about establishing risk with those people and getting them to do it properly. One of the people I think, celebrities are very good now talking about it, and they're very good at raising public awareness. Get your PSA done, look what happened to me. What actually happened with Chris Hoy? He had a family history. He had a whole medical team looking after him. Why on earth did nobody test him early? I think that's a real tragedy. He should sue his medical team. They should have known better. Anyway, that's another hobby horse that I can get on and off with great regularity. Okay. The question you're often asked, I'm sure, when you're running PSA events, somebody will say, what's a normal PSA? What is a normal PSA? I can't tell you until I know another few things about you, particularly your age. Because as you get older, your prostate gets bigger. If you look at somebody, with let's look at a level of, 2.5. Now let's look at a level of 2. That's normal in every age group. Let's do it in a year's time, and it's doubled to 4. In that age group, it is highly, highly abnormal. In that age group, it's quite a worry. But if you're 70 plus, it's still within the normal range. Is that important? Well, yes, it is. Because his PSA has doubled in a year. It may be for other reasons than cancer, but it should put up a little flag. How many of you get your PSA done and you go online to your GP results and there's a thing which says action from GP, normal values? Unless they know that you've had your prostate out, or you've had radiotherapy, or something or other, they're going to say it's normal. You need to look back and see whether it's doubling in a year, don't you? So, so important. Screening events are often criticised for not actually producing enough results. Around about 8% of those attending will have abnormal results. And of those, around 25% probably will have a cancer that needs urgent therapy. When you do them, you need a urology unit on the side, don't you? You're going to create more work for them. You're going to create more work for urology nurses, for surgeons and what have you, because they will want treating. And I have heard GPs who have said, genuinely, I'm not going to do any PSAs because even if it's abnormal, the hospital can't cope. That's horrific. Our job as patients is to get the appropriate tests and the appropriate treatment for patients. How that is done and who pays for that is not my problem. That's a political problem. Get on to your local MP. Is your local MP a member of the all-party parliamentary group on prostate cancer? Do you know?
No, he's not.
If he isn't, why isn't he? Why didn't you go to that meeting about PSA testing? Can I come and talk to you about it, please? Because at the end of the day, the decision about PSA screening will be a political one. If the government have the will and have the drive and say, we are going to have a screening programme, then it will get done. Irrespective of, they will twist the arms of the screening committee, I suspect. So politics are hugely important. They're also important, dare I say it, in charities. And I'm, like I say, being very independent here this evening. Certainly there are egos to be massaged sometimes in getting something done. And it may well be that getting something done is not the whole thing. It may be only PSA screening for those of highest risk. And that's basically going to boil down to black men, people with a known history of the BRCA gene abnormality, people with a family history of prostate cancer or breast or ovarian cancer. So how does that get sent out to from the GP's surgery to the patient to say, please will you come and get screened? Certainly their ethnic background should be part of their medical records, but it may not be. Who knows that they've got a BRCA gene deficiency? About nobody in this room does. So I personally think it's a bit flawed. I'm sorry, but I do. And I've spoken about that very, very openly. You need the support of your local urology service, your local GPs. Again, there is a prostate cancer support group not close to here actually, but who are the group associated with a teaching hospital. Not in London, but elsewhere. That group has been told, if you start doing PSA testing, we're not going to come and talk to you anymore. When back in 2008, when I was diagnosed, very few urology surgeons wanted to have a PSA test done. I worked with 3. They all got prostate cancer later in life. 2 of them have died. It beggars belief. So it's about what do you do with the results that we need. We've gone through that, red, amber and green. That's the sort of follow-up. It's part of the data collection and presentation from a charity called CHAPS and a retired urologist called Chris Booth. It's really quite sensible. It's yet to be fully established, to be fully accepted. But at least it's a start. What are problems? People are still being refused when they shouldn't be. We've already said you should be diagnosed early. 40% of men will have a cancer that's already spread on the day they're told they've got a cancer. 40%. That doesn't necessarily mean it's spread all the way around their body and is an advanced stage. It just means that it's gone outside the prostatic capsule. If the tumour is well enclosed, and you can see that with the multi-parametric MRI these days. That didn't exist in 2008 when I was diagnosed. If it's inside, your treatment options are stunning. Lots and lots of different things you can have now, from radical therapy to focal radiotherapy, all sorts of different things. The moment it's got a little suspicion of being outside, then things go very bad. You can't have some of the treatments. You may need, certainly for surgery, it may be that you need some radiotherapy afterwards as well. All sorts of different things. 19% of men diagnosed have advanced metastatic disease at the moment of diagnosis. 2 weeks ago, I was asked to speak to somebody through a helpline. He's 53. He had no symptoms. He's got a child of, I think 17, just about to do A-levels and stuff. He's got a 19-year-old, 20-year-old currently going through university. As he retired from his large retail company where he was a manager, he'd had a final set of medical things done. His PSA came back at 174. He had no symptoms. Now, that's one end of the spectrum. It's obviously a very broad spectrum. But that's why we've got to get it out there, that early testing is essential. It saves money. It costs around, I don't know, sort of figures they've got, around about 40,000, 50,000 quid to treat somebody with an early stage prostate cancer. It costs a minimum of £500,000 during a chap's lifetime if he has advanced prostate cancer. We can do a lot for advanced disease. Absolutely we can. But it's quite expensive. How many people in that 19% would have ever got to an advanced stage if they'd been treated whilst it was still within the prostate? These are hard facts. We talked about that. And this is a problem. We talk about people at risk in black ethnic communities. They're not the only ones. Diagnosis and outcomes of treatment are terrible, much worse than white men, all the way across the UK. They're worse as you get further north in white men, and the worst outcomes and the lowest rate of diagnosis is in Scotland, for all sorts of different reasons. And yes, there are all sorts of social, religious, whatever, things associated with prostate cancer and treatment and having a rectal examination even. Strangely enough, there was some work done, and as a corollary, they got their PSAs done, but they were offered also the chance to have a DRE done, and black men in that study were very anxious if a man was going to do it. They were much happier if a woman did it. And it's not just black men, it's people of low economic groups, low social caste, low socio-economic status. What about people in Birmingham who are from South Asia? How many of those do you see? How many South Asian people are in this group? No. What about Far Eastern men? Very few. These are other at-risk groups. They're not at risk because they have some sort of genetic thing that might make them more likely to have prostate cancer. They're at risk because they don't come to be tested. And if you come too late, the only thing you know is that people get diagnosed and they die. So why should I come and be tested for something that's going to kill me? It's going to take, not next week, not next year, not 10 years' time, It's going to take a number of generations for us to be able to change sometimes the attitudes of people to certain diseases. Did you know that all right, we have problems with black men not coming for prostate testing? Exactly the same thing is true in South Asian women with breast cancer. It's not a subject you talk about. A South Asian woman would never have her husband come to a hospital appointment if she was being looked at for breast cancer. It's not a subject men talk about. These things are really difficult, but we have to think about them. We really do. We've talked about that. We don't want to waste money. Do it properly. That's what everybody is saying. We are over-diagnosing too many people by doing too many PSA tests, and we're diagnosing prostate cancers which are very minor and will never kill them. That was true when I was treated. I have been grossly over-treated by today's standards. In my day, you had a PSA done, you had a finger up your bum, you may have got a bone scan, PSA, and that's about it. The biopsies were done through the rectum. We had no idea where those needles were going. The ultrasound was a bit like looking at a mist on the screen. And basically the needles were put in a sort of shotgun array, and you hoped you got a bit of cancer out. My test only showed, I think it was 6 positives out of 20, and they were all Gleason 6. But we didn't know about slow-growing tumours then. Had we missed all of the Gleason 10 by bad chance? So we were giving radical therapy, perhaps when today we'd be doing active surveillance for a while, and saving people getting severe side effects. And yeah, I'm free of cancer. But I became totally, and I mean totally incontinent. I really, really sympathised, and I did exactly the same as you. I was not too shocked about the diagnosis because I knew everybody that was going to look after me. But when 6 weeks later you're in the bathroom and you see a pool of urine on the floor and you didn't even know it was there, that was when I broke down. As indeed you were very brave enough to say that you did. And mercifully, it's got a lot better for you. For me, it didn't. And I've got, we can talk about it another day, but I can't remember, I'm talking about incontinence, this group, but I have what's called an artificial urinary sphincter implanted. That changed me from being 96% continent to incontinent to 96% continent. It's got a 10-year life, mine's in its 16th year and still working reasonably well, but it's going to need replacing. That's why I go over time, because I go off piste. Okay. You can reduce mortality with proper PSA screening, proper PSA testing. Comparing, one of the figures that people often use, I haven't put that up. One of the figures they like to quote is how many men do we need to test to save one life? It's a statistic. It's around about 375, I think it is, for prostate cancer. For breast cancer, you've got to screen 1,000 women. For colon cancer, you've got to screen 1,000 people. And nobody really understands that. Nobody really puts it into perspective. That is no reason for not shouting loudly about getting people to get some form of PSA test done. And we've been through that. The survival rate now for early cancers and for advanced cancers aren't actually too different, because we're very good at treating advanced prostate cancer. But, and this is the big but, it's all about quality of life. You may still be alive 10 years later, but you may have very significant reductions in your mobility because you've got bone secondaries. You may be in pain despite having all the magic drugs. So it's all about not just looking, there are two things in life that are important. There's quality of life, really important, and there's quantity of life. And the two really need to be discussed sometimes with people, and that they need to be able to make up their decisions. I think it's John Betjeman or somebody said, if I was given a pill that extended my life by 3 years, and I was going to have another 3 years being gaga in a nursing home, I don't want it. And I think sometimes we have to think about what we are doing. When you're going to look at a screening tool, there are some really good rules that have been established by these people, Wilson, Keppel and Betty, or somebody, Wilson and Newman. It's good with an older age group. They know who Wilson, Keppel and Betty were. It should be an important health problem that you're screened for. That's absolutely true with PSA. The nature should be absolutely and clearly understood, from latent to declared disease. Absolutely true with PSA. There should be a recognised early stage, latent period. Absolutely true with prostate cancer. And there should be a suitable test or examination. And yes, that depends on how you view the PSA at the moment and what else is available. Should be acceptable to the population. Simple blood test, not a problem. Agreed policy on who to treat. We are just getting to that with nice guidance and things like that. And there should be some accepted treatments. We've all got those. That's already established. Facilities for diagnosis and treatment should be available. If they're not, that's not your problem, it's a political one. They need to do something about it. The cost in relation to the economics must add up. And it does with PSA. It's got to be a continuing process. PSA testing for prostate disease and then following on with other investigations fulfills all of those criteria. It's pretty cheap, although it costs through Graham Fulford about 30 quid, in that you're paying for all of the backroom stuff of getting the things sent out to patients, all of the sort of admin stuff that goes. Some groups use their own local hospital and do all the work themselves, and certainly one group I know of, they only get charged 6 quid for a PSA by the local laboratory. And they're certainly not doing that at a loss. But what about, we've got to talk about genetics, haven't we? That's the in thing, other stuff. Who should we be genetically testing? We've not really established that. Yes, perhaps people with family history, people with advanced disease. When do we test in their journey? Where do we test? Does the GP do it? Does the hospital do it? And why are you testing it? Why are you using it? What is your aim from doing this genetic examination particularly? And it can improve diagnostic accuracy. Go back. What are you going to test? How's genetic testing done? It's not just a blood test, which is what most people believe. There are two sorts of testing. One is called, posh word is germ-line testing. That is something which says, this is in my family, we can find it in my bloodstream, like BRCA1, BRCA2 sometimes. That doesn't say you are definitely going to get prostate cancer. If you are BRCA positive, though, something like, I think it's about 17% of all men with advanced disease have got that genetic abnormality. But more accurate is actually doing genetic testing on the prostate tissue itself. I bet none of you realise that your prostate biopsies are kept, I think, 10 years, Mary, something like that?
I honestly wouldn't know. No.
And they're kept in God knows where. The fresher the sample, the better. But you can sometimes get a good positive result 10 years afterwards. Yes, that genetic abnormality, maybe as a result of having the gene in your blood, which affects the prostate. But you can get spontaneous genetic change because of environment or whatever. And that will only be shown up in the prostate tissue itself. So when we're going to talk about mass genetic testing, we've got to be very careful about what we do. Two things. You can use genetics so you can advance treatment, but you can also use genetics to improve your diagnosis skills. Genetics and treatment, there are two major ones that are looked at. There's one called ATM, and it's got nothing to do with cash, but there's the BRCA1 and 2 gene. Why are they important? Because there is a drug called olaparib that can treat patients and reduce their cancer growth by attacking that genetic abnormality. Can't go into that, we haven't got time. But there are a huge number of other genetic abnormalities which have been identified as being associated with prostate cancer. Nobody is saying that any genetic defect is the prima facie cause of prostate cancer. So it's really quite complicated. There's another really fascinating gene called P10, don't know why it's called P10, but it's all about controlling cell death and cell division. And there is a drug called ipatasertib. Let's try saying that when you've had a couple of genes. Which it actually promotes, if you like, early cell death in the cancer cells, but not in normal cells. And there's a lot of research going on looking at targeting just cancer cells with various treatments. Other stuff for diagnosis. And they're not just doing one thing, they're doing what are called protein biomarkers. Proteins in your blood that are associated with prostate cancer. Identifying genetic changes in one shape or form. Putting clinical data together with those results. And doing a free and total PSA, not just what we normally do, which is a total PSA test. PSA is in your bloodstream in two forms. One is free, just floating there happily, and the other is bound up into plasma proteins. So our PSA test measures the whole lot. But we'll talk in a minute about how important that ratio is. There are three very Daily Mail talked about tests. You may not have heard of not all of them. There's one called Stockholm 3, and it measures a whole different gamut of things. It measures total PSA, it measures free PSA, it measures 3 biomarkers which you don't need to worry about, and 101 genetic markers that they believe is associated with potentially producing prostate cancer. And there's all sorts of clinical data age and all that. And they've got an algorithm. They put it all together, and the clever computer works out your risk and looks at your PSA and decides, is this likely to be malignant? And is it likely to be aggressively malignant? The manufacturers say that. There is no comparison that I know of at the moment that's been done. A lot of the data comes from companies. But people are believing that this could be something that might be better in addition to the PSA, perhaps before you even do a biopsy. The question you're going to ask, fine, great, how much does it cost? This particular test is not available on the NHS currently. It costs £395, compared with £30 for your PSA. It's a no-brainer at the moment. Not in everybody. It may be useful in people whose PSAs are very equivocal and are not too sure. There's one called Proclarix, does similar sorts of things, protein biomarkers, free and total PSA. And with both of these tests, it's important to state that they are measuring the PSA at the time then they're measuring all of the other bloods. And that will become important in just a second. How much does that one cost? Oh, it's a software algorithm. And they say it's better at looking at tests that are a bit in a grey area, PSA 2 to 10. About 95% accurate when the score is low, so they say. How much is that one? About 400 quid. Again, not on the NHS. This is that's another blood test called EpiSwitch. That does something slightly different. It looks at how your DNA folds and unfolds. It looks at the structure of your DNA rather than just looking at biomarkers. They think it's much, much better. 94% accurate. If you go on to Dr. Google and you ask for something about the EpiSwitch test, you get a website which goes 94% accurate.com, done by the manufacturers. This one doesn't actually measure your PSA at the time. It looks at unfolding things. That one, £905 privately. And the last one, the Daily Mail said, home testing, spit, fine. It's not home testing, it's home collection. You send off a sample of your saliva to the laboratory and then you get the results back. They do not say it's a diagnostic test, but they're looking at assessing your lifetime risk of prostate cancer. They're telling you what polygenic risks for. That one costs around about £300. Free to total PSA is something which is really cheap. On the NHS, it's free. You just add it on to your PSA normally. Just a little bit of extra. It's already standard practice with Gram-Fulford. If you're using Gram-Fulford, after a certain level of PSA, it kicks in then to take that sample back again and do a free and total PSA measurement. Why? Because the ratio can tell you the likelihood of a cancer. If the ratio of free to total is about 25% or more, then you're probably normal. If it's below 10%, then it's highly recommended that you have a biopsy. There's a lot of... It's never caught on with surgeons. This was around in 2008. And I'm not too sure why the politics of medicine have not allowed this to become standard practice. It's dead easy to do. And it's free at the NHS. If you get it done privately, you can pay anything up to 150, 200, 300 quid. So, I've actually stopped, not badly. I personally believe that the PSA test is a valuable screening tool for initial investigations of patients who may or in fact may not have prostate cancer. It's all about your prostate health, not a screening test for prostate cancer. And it's a cost-effective tool. If you found an abnormality, you go through it. It's a portal, it's a doorway into using more expensive tests. And by doing that first, you get rid of, 65-70% of people who don't need any more expensive tests. It's the best that's currently available. And we spend ages and ages saying, we need a better test and slagging it off. I don't know if anybody's listened recently to Classic FM, and they had a big advertising campaign about breast cancer and screening mammograms. Their buzz line was, won't it be good to know that 75% of you don't have prostate cancer? We're doing it wrongly. We're saying, we're not too sure whether we've got an accurate test or not. We can very easily say that a significant majority of people won't have it. And yes, we do need more sophisticated screening. but it is a long way off, I'm afraid. And that is it. I don't have time to do any more.
Would anybody like to ask questions? No, just hands getting it. Phil. Hold on, I'll get through.
Cheers, Steve, for that. We hear a lot these days about AI.
Yes,
Is that being used?
it
or?
will become more and more important. And where it's being used in a lot of cancers in general is looking at X-rays, looking at MRI scans, looking at pathology slides. And in the early days when they were looking, particularly at trying to look at histology slides, it was very difficult when they were trying to teach the machine to find an abnormal, which is what a human does. What they suddenly thought, and did it the right way, let's teach the machine to recognise normal. Because if it recognises normal, you don't need anything else done. And the AI for breast cancer is picking up tumours that humans can't. So I think it will come. You get a database of perhaps 100,000 scans that it, in 3 seconds, can flick its way through. Yes, it will come. I have personal concerns about diagnosing with a computer. What are your symptoms like? I have great problems sometimes at people who are everything's done on Zoom. You get so much more information with body language, all sorts of things, if you've got that person in the room. Still, there are places, really sadly, where men are being told on a phone call from a nurse that they've got a cancer. That's unacceptable. So yeah, AI, we've got to use it properly. Doesn't matter how we're going to use it, but just use it properly. Yeah.
Cheers.
And people talk about treatment to regret, a horrible phrase. I wish I hadn't had this done, or I wish I'd had that done. You can only make a correct decision with the fullest information. And another buzz phrase at the moment is patient participation in diagnosis, shared decision making. How can you share your decision making if your knowledge is incomplete? You just can't do that. I personally have some problems when we're talking about over-treatment. Yes, I was over-treated. I don't regret that because I did what I did with the best information we had at the time. Yes, it went a bit tits up because I became incontinent and significantly reduced sexual function for a while. But I don't have treatment regret for that. On the other hand, if my incontinence had not been able to be treated with an artificial sphincter, if I'd still had remained, 60% incontinent, I'm not quite sure how I would feel today. So, again, when we're dealing with people who have complications, and let's be honest, the only people that join a support group in the main have problems. You self-select for people who need help. That's what we're here for. But being able to say to somebody, yes, people may not be able to cure you of this side effect, but there are things that can be done to help. There are people who have a Gleason 6, Gleason 3+4, 7, who are told active surveillance is the best thing for you. Around about 50% of people on active surveillance will have treatment at some stage in the first, I think it's 5 years. Either because the disease does progress, but it's picked up very early so that it hasn't spread outside the prostate capsule.
Can you explain the Gleason's for?
Very easily.
What does it?
Right, you look down the microscope and you see abnormal cells. These are graded from 0 to 5. The grading between 0 and 3 is really difficult to separate out. So the minimum that you can actually get is a 3 out of 5. There are two figures that make up your Gleason score. The first figure is the change that is the most common, that's seen under the microscope. And the second figure is the second most common finding. So let's say Gleason 3 plus 3 is a 6, and it means that whatever's happening is widespread through your prostate, but it's fairly minor. May or may not need treating. A Gleason 7 can be a 3 plus 4, where most of the tumour is still fairly, not benign, but slow growing, depending on how many of the samples are positive. But a Gleason 4 plus 3, which is a 7, you need treating. There's a slightly different scale that people are using now called, is it the ISP, the Cambridge something index? Have I got that right? I can't remember it now. I should have looked it up. But yeah, there are men who, despite having a Gleason 6 today, do not want active surveillance. Because what's going to happen? I can't cope with that psychologically. I'm living on a time bomb. Let's get rid of it. Knee-jerk reaction. And despite perhaps going through the complications, that's what they are entitled to have done to them. It's their body. They have a choice of what surgeons do with their body. Now, if they did at Gleason 6 have a radical prostatectomy, say, that would go down as overtreatment. It's not overtreating the patient. He doesn't feel overtreated. He feels correctly treated, because that's what he wants. And all these decisions have to be very carefully mulled over. Does that explain?
Yes, it does. Working out like the Gleason 6, could it be a 1 plus 5?
It's unlikely, because they would have seen that. They would have. It's 3 plus 3 is the lowest score. If you had some Gleason 5, that would come in your Gleason score. It would be very, very, very unusual to have Gleason 5 and only a 1. It would probably be 5 plus 3, 5 plus 4. But it's all about, as well, on the multiparametric MRI, how big is the tumour? Where is it? Is it near the outer capsule? How aggressive it is. From scans, there is now a grading scale called the PIRADS scale, 0 to 5, which can assess or give an inclination of the aggressiveness of the tumour. There's just so much people are doing. Didn't exist in my day.
Very clever. Thanks very much.
Yes.
Okay, I'll come over.
I'm going to make this the last one because I've got to drive back to Reading in a second.
Okay.
And please God, the M40 is all right. It wasn't the other day.
Steve, so what took my interest was you talking about PSA, the 3 plus total. And I was just wondering if that could be applied to monitoring as well as predicting whether the person's got. Could there be an improvement
I
in
don't
monitoring?
know of anybody that does it that way, but it would be possible. Let's say if you were on active surveillance, it's probably irrelevant once you've had treatment,
right,
because you've already got a change and your PSA has altered. You got rid of your prostate, you've had radiotherapy or whatever.
You also mentioned that some of the results are now can either be 0.001 or 0.04.
Yep.
We've noticed in Worcestershire since about April, most of our results have been to 2 decimal places.
Yep.
They've now gone to 1 decimal place. I can't actually find anyone that can properly explain that to me.
I think you
why that's
write
happened.
to the pathology, the bloke who's in charge of your pathology laboratory, or the urology department, and say, please can you explain why? our group is very befuddled because things are being changed. Why is it changed? It's almost certainly because they've used a different machine. But when should we start being worried then? And, you know, I can see the argument of having 3 decimal places. People get far too worried. My PSA started immediately. I was licensed to kill. I got 0.007 immediately after my surgery. It then went slowly up to, and it's now 0.04. That's infinitesimally small increase, although in theory it's doubled. It's background noise. It's, you know, like a bit of mist on the windscreen. It's not relevant.
Do you think that's why they've moved us to 1 decimal place instead of 2, so that people are less worried
I'm
about
a
change?
little bit concerned about only 1. I would like to see 2 if it was me. But just ask them why.
Yeah, I did
Is
today.
this now national
didn't really get an
practice?
explanation.
Yeah,
It might be a new machine, is what I was told.
yes it is. It's an Abbott machine, I
But
think.
you would think it would go more decimal places, not less, wouldn't you, if it was a new machine?
No, because you have to dilute the sample down to get the lower results.
Okay.
And it just takes time, and it may not be for most people really relevant. So you're saving time, effort, and to a certain extent money, I suppose.
Thank you.
Right, as that, I can't remember which comedian was it. Bless you, look, didn't he? Who was that? Charlie somebody, I expect. But thank you for staying awake. It really is a great pleasure to come here. I'd love to come back whenever you want me.